Disciplinary perspectives imprison us, and we have to be a little cautious. The second conflict of interest I want to declare is that I neither work on the planning side nor on the implementation side, but working in academics allows you the freedom of armchair critique. So everybody knows that the mental health burden in India is huge. We have meta-analysis to give us actual figures, which I believe are probably much lower than they are on the ground. If you look at the mental health budget, the health budget is a very small amount of the GDP of India. The mental health budget is even smaller at 2%. The number of beds in mental health is really low. The beds outside mental hospitals, the psychiatric beds in the population very low compared to many countries of similar development and income. Human resources in India are very low. Now, what are the limitations of psychiatric services? They occur mainly in specialist settings. They are done by specialists rather than generalists. They are more in the urban areas. There is very limited psychological and social support. India has virtually no social security net, which makes comprehensive care for mental illness very difficult. And the services are variable, and many places it's a reality that they are non-existent. Now, what are the barriers to service provision? This is a list I shall briefly touch upon. National priorities, health priorities, resources for health, utilization of services, integration of services, advocacy, evidence base, resistance to decentralization, empowerment of physicians, and stigma. Now, what are the national priorities? Health seems in India to be very low priority. Although the UPA government came to pass saying that they would spend 3% of the GDP, I believe that it's only less than 1.5% of the GDP. And I believe the national priority in health is reflected in our funding. If you look at health priorities, physical illness still dominate the health scene. For example, if you take suicide, the official statistics say 10 per 100,000, but maternal mortality is closer to 200 per 100,000 if I'm correct. So infectious disease, maternal mortality, physical disease are still high priority for a country like India. So mental health is competing with other priority conditions. There is limited funding, not just limited funding, there are limited policy initiatives, limited infrastructure, services, and human resources. The utilization of services, there's inequity, there's maldistribution of services, mainly in the urban areas, tertiary care, hospital-based, and there is also inefficiency in its utilization. I must admit that this is one of the central problems, that there is a huge resistance to decentralization. There's a low priority for community and primary care psychiatry. And this is actually a problem, I think, within the psychiatrist community. Mental hospitals and tertiary care still continue to be the main focus of the mental health budget. This issue of empowering physicians, I believe that there are some basic and fundamental problems. Physicians are currently trained in psychiatry in specialist settings. They see exotic, chronic, and difficult cases. And when they go back to their primary care settings, they're not able to make out either the classic syndromes or the milder conditions, because they have been taught using specialist perspectives and not general physician perspectives. There is also a very brief time in training. We have huge stigma related to mental illness, and in 21st century our attitudes lag behind, and there is a need for mass education. As people have mentioned, mental health advocacy is fragmented, there is no unified plan, there is a competition within the sub-disciplines of mental health and within advocacy groups, and this is a huge problem. If you ask me, what is the problem with the Mental Health Act? And there are problems, But I don't think we are able to get together to come up with a solution. There's so much fragmentation of mental health advocacy. This is another issue, the evidence base for mental health interventions. I agree that much of it is based on Western data. The Indian trials of efficacy and effectiveness are limited. Although work has been done in Nihans and in Chandigarh, I believe that we are not using these interventions to argue our case. This integration with general healthcare is the biggest problem. There is poor or no integration. There is low priority for generalist training like family medicine. Family medicine as a specialty hasn't taken off. General practice as a specialty hasn't taken off in India. Psychiatric care continues as part of a specialist discipline in isolation from general health care. Now, what would be the solutions? I believe we need to revamp basic training, integrate with general health care, as Professor Mohan Isaac was mentioning, come up with intersectoral cooperation and collaboration, look at funding, mental health education, and mental health leadership. I believe psychiatry should be taught in general hospital settings, using physician perspectives, discussing common presentations which are seen in general hospitals, rather than be based in tertiary care centers. If you look at chronic schizophrenia in a mental hospital, that's very obvious. But when you have to treat acute psychosis presenting in a general hospital, the problems become very difficult. You don't know whether it's schizophrenia or bipolar. When you see classic depression in a mental hospital and then look at mixed anxiety depression in primary care, you're not able to decide what is the diagnosis, and then you can't proceed to management. So I believe that we need to shift psychiatric training from tertiary care to medical settings. We need to use physician perspectives. We need to look at common presentations, which is actually psychosis and unexplained somatic complaints, substance use, maybe dementia and delirium in secondary hospitals. We've been working in CMC trying to shift this to the community, and we find that we need a complete change in the way we teach our medical students and our colleagues in other specialties. I believe that if there is a clinical exam, not conducted by psychiatrists, but as part of the internal medicine posting, using acute psychosis and unexplained medical symptoms which are common presentations, I believe that the future doctors would be adequately skilled to manage these conditions. So without revamping basic training, no amount of add-on, once you've been taught to be a doctor, to say come and attend a short course which will transmit knowledge but won't give you skill, I don't think that is a solution. We need to revamp basic training. And this basic training should be revamped across disciplines in medicine, medical, nursing, paramedical, psychology, social work and counseling. We really have to integrate with general health care. There is really no other option. This integration would be possible if basic training is sorted out. Once you get a doctor or a nurse or a specialist who is not trained in skill and confidence, then no matter what short course you conduct, and I am sure zillions of short courses have been conducted, they just don't have, the short courses don't transmit skill and confidence. So people are then reluctant, despite the fact that they've been trained, to actually take up this management. I believe the National Rural Health Mission and the Urban Mission, which is now coming in, is a good platform to piggyback, but I believe that without sorting out our basic training issues, it would be difficult. There should be intersectoral collaboration with departments of social justice, women's empowerment, law, rural development, education, employment, human rights, and with non-governmental organizations. Without such an intersectoral thrust, I don't see how mental health issues can be sorted. So it's not just a medical issue, this cuts across the board, and unless we approach it from all these sectors and come up with a unified program, it will be very difficult. Funding, of course, should be increased. It should be ring-fenced. I believe that we don't get this kind of ring-fenced funding. Already the health budget is very small. Mental health budget is even more minuscule. So the money coming in, despite the fact that many 100 crores have been promised, is actually very, very small. Mental health education is a major challenge. We need to use the mass media to change attitudes. I believe that we also need a change in mental health leadership. There needs to be more cooperation within the various mental health disciplines, and definitely there needs to be a change of attitude across the board. Different disciplines have different attitudes which actually interfere, and I believe that all involved in mental health leadership should be able to make this change. I feel that we need to get the knowledge base, come up with strategies of what we need to implement, and also come up with the political will to act. I feel that without an integration into general health care, without revamping our basic medical training, we will always have a shortage of specialists, and care will be always then located in tertiary care, which I believe is highly stigmatizing. And if you want to reduce stigma, we need to move it into primary and secondary hospitals. Thank you.
Don't happen in India? I thoroughly disagree. Amongst us here in this room is a very great survivor, my guru, Bhargavi Davar, who is Indian. When I say I'm a survivor, I know what I'm talking about. My narrative hasn't spoken of many morbid things because of a lack of time or inadequate time. What changed my life was her book. I urge Bhargavi to speak as an Indian survivor. So he says, and this person said, survivor isn't a word to be used in India. So what do you say, Bhargavi?
With you all, who is really interested in the welfare of the disabled and also to improve this innovative program, there is a district mental health program. After the post-independence, there is a only innovative program which is coordinated by the government of India is the district mental health program. It is a community-based mental health program. And in Tamil Nadu, we are the highest one, and we are implementing in 16 districts in Tamil Nadu district mental health program. And so far we have completed 3 districts, and in 13 districts we are implementing this program, and we have submitted the proposal for 6 more districts. This is the name of the district, and the proposed district is Coimbatore, Dindigul, Pudukkottai, Sivagangai, Thoothukudi and Viluppuram. But unfortunately, the Nilagiri is left out. And the aim of the district mental health program, my dear ladies and gentlemen, according to the WHO, 3% of the population is suffering from the serious type of psychiatric